Hello friends, welcome to my YouTube channel TNC Updates Toxicology and Critical Care. So in today's video we are going to talk about a very important topic which is one of the most important investigation in ICU. Before we start the video, let me tell you about this investigation. It is ABG which can tell you so much about underlying metabolic conditions. We will try to learn in this video some practical examples of various ABGs, how we have to read it, what are the various steps of doing it, and how do we correlate clinically. So, a disclaimer to start with, the following video touches various important topics of critical care medicine and toxicology. The videos are not exhaustive account of the disease conditions discussed. The videos derive their content from various standard textbooks of medicine, critical care, and toxicology, but as the guidelines change rapidly as per the new level of evidence, the viewers are strictly advised to follow the discretion and advice of the treating specialist. So, basic concept: the human body is governed by something very basic. It's a beautiful versatile thing which has been created in equilibrium by the Almighty. So, ABG tells you how the human body is governed by mathematics. So, what is the basic underlying concept? It is the hydrogen ion concentration in the body fluids that defines the acid base balance. Though rightfully, the hydrogen ions are protons which don't exist in isolation in the body fluids, but react with water to form hydronium ions. Further, the absolute concentration of H positive in the plasma is very minimum and is measured in nanomoles per liter, which is difficult to manipulate and requires an extremely sensitive process in order to maintain it within normal limits. Hence, the concept of pH was developed. pH is negative logarithm of hydrogen ion concentration and is not expressed as specific units. Normal range is 7.35 to 7.45. So 7.40, when we say, it represents what? 40 nanomoles per liter of hydrogen ion concentration. Lower the pH, greater the hydrogen ion concentration, and vice versa. So basically, human body is regulated by this equilibrium, and it doesn't tolerate to go out of the equilibrium way possible. So when the equilibrium goes haywire, the life gets threatened. We will see it. So the buffer system: H2O plus CO2 carbonic acid, H positive plus bicarbonate. The two main excretory organs are lungs and kidneys. There are two classes of acids in the body: the carbonic acid and non-carbonic acid, which are generated daily in the body. The carbonic acid is generated by metabolism of carbohydrates and fats. In fact, it is a large amount of carbon dioxide which is generated, which combines with water to form carbonic acid, and excess carbon dioxide is washed by the lungs. Thus, if there is alveolar hypoventilation, it will accumulate this acid. The non-carbonic acid is primarily generated by metabolism of proteins and is eliminated initially by combining with bicarbonates and subsequently excreted by kidneys as H positive and bicarbonate by kidneys. So basically, in short, whatever you eat, whether it is carbohydrates, fats, or proteins, they will be converted into two types of acids: carbonic, non-carbonic acid, and they will be excreted through two main systems which try to compensate each other. So, lungs and kidneys. Thus, the primary respiratory imbalance is compensated by metabolic component, and the metabolic imbalance is compensated by respiratory component. So there were two people, Henderson and Hazelbeck, who formed an equation for the above balance in the human body. They said pH is pK plus logarithm of bicarbonate plus H2CO2. H2CO3. The equation explains the relationship between blood pH and acid-base balance determined by the main H2CO3 by bicarbonate buffer system. As concentration of H2CO3 is difficult to measure, and since it is in equilibrium with carbon dioxide, pH is equal to pK plus log of bicarbonate plus, so the H2CO3 was substituted by PaCO2. Basically, what we try to understand is pH is kidneys upon lungs. It is the process followed by kidneys is a slow process, whereas PaCO2 washout by lungs respiratory system is a fast process. Since the kidneys affect bicarbonate and change it slowly, and the lungs wash out carbon dioxide rapidly, the ratio can be understood as slow divided by fast. This concept shows why pH corrects slowly in respiratory events, whereas bicarbonates are corrected. So, whenever you get a person in emergency who has got a basic problem in the respiratory system, they will deteriorate very fast because the uh, uh, it is the pH is governed by this equation, slow upon fast. Whenever there is a respiratory problem in the body, so they need compensation by the kidneys, but the kidneys are a slow process. But whenever there is a metabolic disturbance in the body, the respiratory system tries to compensate it. So metabolic events will always give you time, but respiratory events, suppose there is a retention of PCO2 because of some sedative overuse, the patients will deteriorate very fast because PCO2 will start rising and bicarbonates as a compensation will be able to compensate for it in a slow process. So you have to understand pH is equal to pK plus log of bicarbonate upon PaCO2, which is a slow by fast process. So we see in practice that respiratory problems deteriorate very fast, whereas metabolic problems always give us time. So primary acid base disorders and the secondary response. What are the basic things? Metabolic acidosis, metabolic alkalosis, acute respiratory acidosis, acute respiratory alkalosis, chronic respiratory acidosis, and chronic respiratory alkalosis. Whenever we have a patient metabolic acidosis, primary disturbance bicarb goes down, secondary response PaCO2 goes down, and what is the magnitude of response in metabolic acidosis? Delta PaCO2 1.2 multiplied by delta bicarbonate, and time to complete compensation 12 to 24 hours. Metabolic alkalosis, so bicarbonate goes up, PaCO2 goes up. So arrow is same on the side when compensation takes place. And what is the delta PaCO2? It is zero point 0.7 multiplied by delta bicarbonate. Time to complete compensation 12 to 24 hours. Acute respiratory acidosis, when the patient is having a respiratory problem, PaCO2 goes up, bicarb goes up, and what is the change in bicarb? It is a factor of only 0.1. So this was what I was talking about. It is a very slow process. It changes only by zero point 0.1 into delta PaCO2 and less than 6 hours. Acute respiratory alkalosis, it goes down, bicarbonate goes down, and delta bicarb is zero point 0.2 into delta PaCO2, less than 6 hours. Chronic respiratory acidosis. So there are factor changes in chronic respiratory acidosis as well as in chronic respiratory alkalosis by a factor of zero point 0.4. So you see here, uh, you have metabolic acidosis and alkalosis, but respiratory, whether it is respiratory acidosis or alkalosis, we have acute and chronic categories. So, I think this is very important. These are three groups we will see in clinical setups. We can divide all patients on the basis of two variables. One is pH and one is PaCO2. So if pH and PaCO2 go in opposite direction, the primary pathology has to be respiratory. So if pH goes down, PaCO2 goes up, it is respiratory acidosis. If pH goes up, PCO2 goes down, it is respiratory alkalosis. If pH goes down and PCO2 also goes down, then it is in the same direction. So it is metabolic acidosis. And if pH goes up and PCO2 goes up, it is metabolic alkalosis. So to sum it up, the group 1 has various disorders in which if pH and PCO2 goes in opposite directions, we have respiratory problem. If they go in same direction, we have a metabolic problem. Now group 2, we have a normal pH and a PCO2 goes up. So a normal pH is there, but PCO2 is high. That means bicarb must have gone high. So it can be two things. It is either chronic respiratory acidosis or a mixed disorder with respiratory acidosis plus metabolic alkalosis. Group 2 also has a normal pH with PCO2 goes down. If pH is normal, that means PCO2 has gone down, so bicarb must have gone down also. So it is a respiratory alkalosis plus metabolic acidosis, a mixed disorder, or it can be a chronic respiratory alkalosis also. Now, group 3, these are patients where pH gets disturbed. pH goes down and PCO2 is normal. If pH has gone down, bicarb goes down. So PCO2 should have gone down. So, but this is retention. So it is respiratory acidosis plus metabolic acidosis. Group 3, pH goes up and this is again normal. So pH has gone up, bicarbonate has gone up. But uh, we expect the PCO2 should also gone up, but this is normal. So it is what? It is metabolic alkalosis with respiratory alkalosis. So these are three basically groups we must try to understand according to pH and PCO2 values. So causes of mixed disorders in ICU. First, septic shock, salicylate overdose. So high nine gap metabolic acidosis. We will try to learn about nine gaps, what it is, and how do you interpret all that. Plus respiratory. Whenever you have a septic shock or a salicylate overdose patient in the ICU in the initial few hours, they will be hyperventilating. So there is high anion gap metabolic acidosis plus respiratory alkalosis. Cardiorespiratory arrest, so they are arrested near arrest patients. They will be retaining carbon dioxide. So there will be high anion gap metabolic acidosis plus respiratory acidosis. You are having so much use of diuretics in ICU, vomitings in patient coming to ICU. So with chronic lung disease, diuretics, vomiting, these are one of the two of the most common causes of metabolic alkalosis. So metabolic alkalosis plus respiratory acidosis due to a chronic lung disease. So these are mixed disorders, what we were talking in the previous slide. Clinical, what the patients will be presenting with. So vomiting, use of diuretics in a patient with ketoacidosis or a lactic acidosis due to some infection. So vomiting and use of diuretics will cause metabolic alkalosis, and ketoacidosis or sepsis, this will be causing high anion gap metabolic acidosis. So alkalosis, metabolic alkalosis and metabolic acidosis can coexist together, but respiratory alkalosis and respiratory acidosis can't coexist because the organ is same, lungs. So here the mechanism is different. Vomiting and use of diuretics and ketoacids or lactic acidosis, the mechanism both are different, but there the organ is same, so you can't have coexistence of respiratory alkalosis and acidosis, but you can have coexistence of metabolic alkalosis and high anion gap metabolic acidosis. Use of diuretic or vomiting in a patient of hepatic failure, pneumonia with vomitings. So diuretic vomiting again will cause metabolic alkalosis. If they are having a pneumonia, they will be hyperventilating, something like that. Respiratory alkalosis. So COPD patient will be respiratory acidosis, and for pneumonia patients or uh, salicylate poisoning or ARDS initial stages, they will be respiratory alkalosis. Diarrhea in a patient with lactic acidosis. Now, diarrhea will cause, we will see in the next few slides, a normal anion gap, a hyperchloremic metabolic acidosis, but a lactic acidosis called. So, two types of acidosis can also coexist together. So, before we start the first look, the ABG report should not always be accepted as at face value, as it may not be physiologically correct and may misdiagnose an acid-base disorder. To ascertain the physiological correctness of ABG, one may refer to the following equation, that is H positive is equal to 24 into PaCO2 divided by bicarb. So this is very important. You, before starting with your interpretation, you should try to understand whether it is a normal ABG or it is not a right ABG. So this will give us H positive is equal to 24 into PaCO2 divided by bicarbonate. The above equation will only apply to primary acid-base disorders with secondary response. The most important variant that should raise a red flag, that is pH less than 7.25. It indicates something wrong, something drastically wrong, and it should draw an immediate response from the intensivist. Making sense of pH. Human body is in equilibrium because of pH. And this is the value we have to maintain, 7.35 to 7.45, or more precise, 7.4. And 7.4 indicates a hydrogen ion concentration of 40 nanomoles per liter. pH of 4 means 10 raised to power minus 4 millimoles of hydrogen ion. pH of 7 means 10 raised to the power minus 7 millimoles per liter of hydrogen ion. Thus, a pH difference of just 3 results in concentration of 1000 times. Thus, one should understand the importance and weightage of decimal points even in pH. So, it is one test where you have to even uh, give so much importance to the decimal points also. So, 6 steps to the interpretation of ABG. First look, we will try to find whether the ABG is normal, ABG is abnormal, is the ABG physiologically correct, whether uh, it correlates with my clinical findings, does it suggest a critical condition, determine the type of acid-base disorder, determine the degree of secondary compensation, assess mixed acid-base disorders, calculate the gaps, we will talk about the gaps, analyze the metabolic alkalosis part. So we will be talking in examples with clinical practical examples. Before we start with the clinical examples, we must know something in background, what causes metabolic acidosis, normal anion gap and high anion gap. Normal anion gap metabolic acidosis, diarrhea, renal tubular acidosis, early renal insufficiency, rapid isotonic saline infusions, calcium chloride injections, magnesium sulfate causing diarrheas, cholestyrene, ileal conduits, pancreatic fistulas. What is the cause of high anion gap metabolic acidosis? Ethylene glycol injections, oxoprolines, lactic acidosis, D-lactic acids, methanol, aspirin, salicylate toxicities, end-stage renal failures, ketoacidosis. So you see practically patients coming with sepsis, renal diseases, hepatic end-stage liver failure, all these present with high 9-gap lactic acidosis. So, what are the causes of metabolic acidosis? We normally divide into two subgroups: chloride responsive, that is urinary chloride less than 15 millicoulombs per liter, volume depleted states, hypovolemia, antacids, nasogastric aspiration and vomiting, diuretics, thiazides, and loop diuretics. Chloride resistant, urinary chloride more than 25, volume overloaded states, Cushing syndrome, renovascular hypertension, primary aldosteronism, severe hypomagnesemia, severe potassium depletions. Steroids are so much used in ICUs and hospitals. Exogenous glucocorticoids and mineral corticoids. They can be a cause of metabolic alkalosis. Making sense of anion gap. Anion gap is unmeasured anions minus unmeasured cations. Two equations. First is unmeasured anions minus unmeasured cations. Second is anion gap is also equal to sodium plus potassium minus chloride plus bicarbonate. The anions that are not regularly measured are albumin, phosphates, sulfates. Normal anion gap can vary from 8 to 16 millicoulombs per liter. Anion gap is proportional to plasma albumin concentration. Hence, in severe hyperalbuminemia, the baseline normal value of anion gap is falsely lowered and may mask the presence of high anion gap metabolic acidosis. So, many patients who are critically ill, they do have hyperalbuminemia. So when you measure anion gap in these patients and you say, sir, the anion gap is normal, and I say, oh, anion gap is normal, that doesn't mean it is a true finding. You have to correct that finding by this equation. Corrected anion gap is equal to measured anion gap, and a factor of 2.5 is multiplied by the albumin concentration, which is down. So this will give you the correct anion gap, and this is the equation you will be using to uh, correlate the exact anion gap in those patients. Human body is governed by electron neutrality. Human body tries to maintain the charges in it in a neutral position. There are positive charges, there are negative charges. It's all physics and mathematics going in your body. The underlying principle is electron neutrality. It is just physics what we used to learn. So raised anion gap can result, the equation first is unmeasured anions minus unmeasured cations. So raised anion gap can result from either a decrease in unmeasured cations or an increase of unmeasured anions. Because you have to just say, we will just write here unmeasured anions minus unmeasured cations. So whenever anions goes up, the anion gap will go up. Whenever cations goes up, the anion gap will go down. So disorders in body which result in increase of unmeasured anions will increase the anion gap. This is very common. But unmeasured cations increase, like for example, you have got some disorders in which there is a hypercalcemia. So theoretically, in those disorders, anion gap will go down. So in metabolic acidosis, there is a reduction of serum bicarbonate. Just 1 minute, I get the laser point. So in metabolic acidosis, there is a reduction of serum bicarbonate. To maintain electron neutrality, this reduction in measured anion is accompanied by either an increase in serum chloride, the only other measured anion, or much more commonly an increase in unmeasured anions. So two things are possible in metabolic acidosis. First is, whenever bicarbonate goes down, chloride increases. If chloride increases to maintain the electron neutrality, so in that case, the equation, that is sodium plus potassium minus chloride plus bicarbonate. Bicarb goes down, chloride goes up. The anion gap is sodium plus potassium minus chloride plus bicarbonate. So in that case, the anion gap will stay okay. But It is a metabolic acidosis. So what type of metabolic acidosis is? It is hyperchloremic normal anion gap metabolic acidosis. In second type, where bicarbonate goes down but chloride doesn't increase to maintain the electron neutrality, but something else increases to maintain the electron neutrality. It can be lactate, it can be sulfate, it can be phosphate. So in those disorders where the chloride doesn't increase, those cases are called non high anion gap metabolic acidosis. So lactic acidosis is the most common cause, which is the second type of high anion, increased anion gap metabolic acidosis. It results because of accumulation of lactic acids, leads to reduction of bicarbonate because of buffering of H positive ions released by lactic acids, finally resulting in accumulation of unmeasured anions, that is lactate. So whenever lactic acid accumulates, the H positive will need something to combine, and it combines with HCO3 negative. So HCO3 goes down, and what increases instead of HCO3? Lactate. So electron neutrality is maintained, but it results in high anion gap metabolic acidosis. Marked increments, this I talked earlier, in the levels of cations. So this you won't see that much in practice. In diabetic ketoacidosis, the increased anion gap is due to increased concentration of unmeasured anions. So they are basically beta hydroxybutyrate and acetoacetates. Uh, we talked about anion gap. Another very important gap is delta gap, or the gap ratio. Delta gap is the comparing of two gaps, the anion gap excess in the high anion gap acidosis versus the bicarbonate deficit. For every 1 milliculant rise in the anion gap, there should be a concomitant 1 milliculant fall in bicarbonate. So delta gap is to be used only in high anion gap metabolic acidosis. In high anion gap metabolic acidosis, delta gap, what we expect is that every 1 milliculant increase in anion gap above normal, it will be offset by 1 milliculant decrease in fall in bicarbonate. So delta gap is measured anion gap minus normal upper limit of anion gap divided by normal bicarbonate minus measured bicarbonate. So this equation you have to remember. We will be using it in clinical scenarios. We can also subtract the denominator value from the numerator, and the normal difference is up to 6. The above ratio helps us to determine the presence of additional primary metabolic process, acidosis or alkalosis, in a pre-existing high anion gap metabolic acidosis. So if it is pure high anion gap metabolic acidosis, we won't have any significant delta gap. But if there is a primary metabolic process which is going on, say metabolic alkalosis, then we will have a delta gap which is significant. We will see in the practical examples. Interpretation of delta gap. In coexisting non-anion gap metabolic acidosis, the ratio is less than 1. For example, diarrhea, because here denominator is more than the numerator. So in normal anion gap metabolic acidosis, the what is the numerator? Numerator is a, it is a normal anion gap. So there is a zero thing is there, no anion gap is there, so normal anion gap, there is no difference, and but the denominator will become more because the body is, for example in diarrhea, the body is going into metabolic acidosis, losing bicarbonates. In high anion gap metabolic acidosis, the ratio is 1. So this I already explained. If there is hidden primary metabolic alkalosis, the ratio is more than 1, because the bicarbonate here is higher than expected, making the denominator lesser than the numerator. One other method used is subtracting denominator from numerator. If there is independent process like metabolic alkalosis, the denominator, normal bicarbonate measured minus measured bicarbonate, will be on lesser side, and thus the difference between the two will be more than 6. We will see in the This may sound a bit complicated, but we will see in the clinical examples, and it will get well elucidated there. So, a 44-year-old female presents to the emergency history of nausea, recurrent vomiting since 3 days. She gives history of consumption of several aspirin tablets. So, for joint pains, ABG shows pH 7.756, PCO2 35, bicarbs 33 millicoulombs per liter. Let us interpret this ABG. So, what are the choices? He asks whether it is a valid ABG, metabolic alkalosis with respiratory alkalosis, invalid ABG, respiratory alkalosis plus metabolic acidosis, a valid ABG with metabolic alkalosis. So, what will be your choice? Let us do the stepwise interpretation. First, see whether it is in valid ABG. H positive is equal to 24 into PCO2, which is 35 divided by carb 33. Around 25 it comes. 25 corresponds, so 25 uh, corresponds to a pH between 7.5 and 7.6. So the pH over here given is 7.56. So it's a valid AVG. So here if we say pH has gone up and PCO2 has gone down, so both have in the opposite direction, so its primary pathology has to be respiratory alkalosis and secondary compensation. So primary pathology is respiratory alkalosis, so delta bicarbonate, the equation will be zero point 0.2 factor of zero point 0.2 multiplication by the change in PaCO2. Zero point 0.2 multiply 40 minus 35, that comes to 1. So bicarbonate expected is 23, and what is the bicarbonate actual? Uh, it is 33. So the disorder is respiratory alkalosis with metabolic alkalosis going on in the body. Let's do it. Second, a person was admitted in a coma. The ABG was done. PCO2 gives us 16 millimeters of mercury, bicarbonates 5 millimoles per liter, pH 7.1. What is the underlying acid-base disorder? Whether it is metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. As you see, the pH has gone down, PCO2 has gone down, so it's a metabolic disorder. So, metabolic acidosis. So, in metabolic acidosis, respiratory compensation is a factor of maximum factor, that is 1.2 multiplication bicarbonate. So, 1.2 into 25.2. So, the correction has to be by 25.2. So, in metabolic acidosis, expected PCO2 will be 15.8, and it's 16 given in the example, so it is almost complete. So it is not a case of any mixed disorder, it is a primary one, that is a metabolic acidosis. So these are the steps one should try to follow. First, try to validate the ABG, try to find the primary disorder, try to find the secondary compensation which is expected, and then you go for any gaps, etc. Gaps we will learn again in examples. Let's do it. A young woman brought to the emergency. She was found comatose. Sleeping pills bottles was found near her. Relatives don't have the information of the number of pills consumed. That is a very common scenario in ICUs. And timing of consumption of pills. ABG shows pH 6.90, bicarbs 13, PaCO2 68. How will you describe a disorder? Whether it is uncompensated metabolic acidosis, uh, or whether it is uncompensated respiratory acidosis. So we have to see whether it is simultaneous respiratory metabolic acidosis, respiratory acidosis with partial renal compensation. Out of the four, what do you say? How will you say what the woman is having? So first thing, pH and PCO2. pH has gone to 6.9, PCO to 68, opposite direction. So the primary disorder is respiratory acidosis. So expected bicarbonate is 0.1 factor, PCO2 68 minus 2.8. Expected bicarbonate, PCO2 goes up, bicarbonate expected is 26.8, and this is 13 milliequivalents. So it is definitely she is having primary respiratory acidosis with a metabolic component, that is respiratory and metabolic acidosis together. So let's do it. A 40-year man brought to emergency room after he was found lying in a street with an empty liquor bottle nearby. On examination, BP is 120 by 80, pulse is 110, respiration rate is 28. He was unresponsive, pupils reacting to light, labs PABG done, 7.1 pH, PCO2 36, PO2 90, sodium 145, potassium 4.5, chloride 97, blood urea nitrogen 23, creat 1.3, blood sugar levels 110, lactates 1 millimole per liter, ketones negative, salicylates negative. What type of disorder you think this have? What is the anion gap? Can you calculate that? And what is the delta gap in this patient? So taking it as a valid ABG, let's find out the bicarbonate. Uh, so taking it as a valid ABG, we will find out bicarbonate. Okay, let me put the formula. What we had, was that hydrogen ion concentration H positive is equal to 24 multiplied by PCO2 divided by HCO3. So that was it. So in this question, we are having, we are given the pH. pH is what? 7.1. So pH 7.1 in the one of the slide I showed you earlier. 7.1 is acidosis, and it correlates with the hydrogen ion concentration of 80. So 80 is equal to 24 by into PCO2. PCO2 is 36. So 36 divided by bicarbonate. So bicarbonate you can calculate, it comes to 10.8. As pH and PCO2, pH is going down, move in same direction, so it is metabolic acidosis. So checking for respiratory compensation. So 1.2 as a factor. One we have calculated the bicarbonate. So 1.2 into 24 minus 10.8. So 15.84 is the correction we need to do. Expected PCO2 is 40 minus 16, that is 24. But what is the actual PCO2 we found in the ABG? So 36. So it is metabolic acidosis with respiratory acidosis. So it is simultaneously going on, both together. So anion gap. So anion gap, what is the formula? So anion gap, let me take the laser point again. So anion gap is sodium plus potassium minus chloride plus bicarbonate. So 41.7. So delta gap is equal to measured anion gap minus upper normal anion gap, normal bicarb minus measured bicarb. So 41.7 is the measured anion gap, and upper normal we take it around 15. So normal anion gap is 8 to 16, and the upper normal limit we take is 15. 41.7 minus 15 and divide minus. So there are two ways, we either we divide or we take the difference of the numerator and denominator. So denominator is normal bicarb minus measured bicarb, what we have calculated by this method. So 24 minus 10.8 comes to 13.5. So it is more than 6. So it is a case of high anion gap, metabolic acidosis, respiratory acidosis plus metabolic alkalosis. So three disorders are going on together. Let's do it. A 21-year-old engineering student rushed to the hospital due to vomiting, decreased level of consciousness. On examination, patient is lethargic, irritable in response to stimulation. He appears to be very dehydrated. His eyes are sunken, past mucous membrane. He has 2 weeks history of polydipsia, polyuria, and weight loss. See, everyone knows about this disorder, but let us try to interpret the ABG. That is the target. ABG is equal to pH is equal to 7.0, PCO2 is equal to 90, PCO2 is 23, 5.5. Labs give us H positive is 24 into PCO2 23.5.5 times bicarbonate, that comes to 156, 100 corresponds to pH of 7. So pH and PCO2 move in the same direction. PCO2 has gone to uh, 23, and this is a primary disorder, has to be metabolic acidosis, and PCO2 expected we have to multiply with a factor of 1.2, 1.2 multiplied by carbonate change 24 minus 5.5, 22.2. Expected PCO2 is 44, 40 minus the change 22.2 is 17.8. So what is the PCO2? 23. So slight respiratory acidosis is there. So actual PCO2, so it is basically a metabolic acidosis with slight respiratory acidosis. Anion gap, if we try to calculate, anion gap is equal to sodium plus potassium minus chloride plus bicarbs. So it comes to 30.5. It's a high anion gap metabolic acidosis. If we calculate the delta gap is upper limit of the anion gap minus anion gap, which will be calculated, minus the upper limit of normal anion gap minus 15, minus normal bicarb minus actual bicarb. So that comes to 15.5 minus 18.5 minus 3. So what does minus 3 means? Always remember that if delta gap is significantly negative, that is less than 6, then a non-anion gap metabolic acidosis, that is hyperchloremic acidosis, is usually present, because the rise in anion gap is less than the fall in the bicarbonate. So it is a basically a disorder of metabolic acidosis with slight respiratory acidosis with normal anion gap metabolic acidosis also present in this disorder. Let's do it. A 72-year-old male with COPD presents with breathlessness, fever. Very common scenarios in ICUs. So pH, we do the ABG of this patient. So pH is 7.25, PCO2 is 80, bicarb is 34, and PO2 is 39, and SaO2 is 54%. Pulse is 130, and the respiration rate is 32, BP is 130 by 110, temperature is febrile, TLC is 18,000, sodium is 140, potassium is 4.1, bicarb is 36, chloride is 89. So this is a very common scenario. These are the initial investigations done in every basic ICU. So let us do the validity of this ABG. H positive is 24 into PCO2, that is 80 divided by bicarb, 36, that comes to 53. So 53 corresponds to pH of around 7.25 as per our table. So it's a valid ABG. pH has gone down and PCO2 has gone up. So it's a respiratory disorder, respiratory acidosis. Checking for, so we have checked for the metabolic compensation. Metabolic compensation, as he is a patient of COPD, it's a chronic respiratory problem. So the factor multiplication is 0.4, 0.4, 80 into minus 40. That is the 80, that is 0.4 multiplied by the his PCO2 is 80 and normal we take is at 40, and 16 is the factor of correction. So expected bicarbonate will be 24 plus 16, that is 40. And what is the actual bicarbonate? Actual bicarbonate is equal to uh, 34. So it's a bit of metabolic alkalosis also, 34 and 36. So both are going together. So it is a basically a respiratory acidosis plus metabolic alkalosis going together. A 9 gap, if we calculate sodium plus potassium minus chloride plus bicarbonate, that comes to 19.1. It's high 9 gap metabolic acidosis. Delta gap, Delta gap, if we calculate, that is a 9 gap minus 15 minus 24 minus 36, so it's a minus 8.1. So it's a case of chronic respiratory disorder with metabolic acidosis, which has gone some correction, both high as metabolic acidosis plus metabolic. So it is normal 9 gap acidosis plus high 9 gap metabolic acidosis with chronic respiratory acidosis. We go about the interpretation. Go to the next example. Let's do it. A 32-year-old male admitted with history of diarrhea since 2 days. APG pH comes to 7.31 and PCO2 comes to 33, bicarb is 16, PO2 is 93, chloride 108, potassium 2.9, sodium 134. What is the acid-base disorder? So out of these, high 9 metabolic acidosis, metabolic alkalosis, respiratory acidosis, metabolic alkalosis, respiratory alkalosis, or normal 9 gap acidosis. So validity, H positive is 24 into PCO2, that is 33 divided by bicarbonate 16, 49, so corresponds to a pH of around 7.30, so it is okay. pH and PCO2, they move in same direction, so it is a metabolic acidosis. Secondary compensation, if we check for, so PCO2 compensation is factor of 1.2 multiplied 24 minus 16, so 9.6. Expected PCO2 will be 40.9 minus 9.6, 30.4. So 33 is our actual one. So it's almost enormous. It's compensated. Then we will calculate. So 9 minus 124, that is 10. So we take the normal 9 gap, normal as, so it's basically a normal 9 gap, normal 9 gap, 5 to 15 is normal, normal 9 gap metabolic acidosis. So, after giving these examples, a word about lactic acidosis. Causes are divided into two types, type A, type B. In ICU patients, type A is commonly seen in patients of shock or severe organ oxygen desaturation, whereas type B is can lead to excessive lactate production, sepsis or thiamine deficiency, decreased lactate metabolism, liver failure, impaired oxygen utilization by the tissues, metformin, paracetamol, cyanide poisoning, certain antiretroviral agents, beta-agonist agents. D-lactic acids occurs in a subset of patients with high 9-gap metabolic acidosis following accumulation of D-lactate. It usually doesn't show up on normal testing or only it is borderline high, 2 to 3. So this is a disorder in which you will have a lactate level normal, but a 9-gap will be high. So why it occurs? Because uh, the test we are doing in our hospitals, it doesn't detect D-lactic acid. It only detects the L form. It occurs in patients with small bowel resection or jejunal bypass, where large amounts of carbohydrates are directly delivered into the colon, which otherwise would have been reabsorbed in the small intestine in a patient with normal gut. The high load of carbohydrate driven to the colon is metabolized to D-lactate by the colonic bacteria and is absorbed in circulation. Hence, following a heavy carbohydrate diet, these patients will succumb to metabolic acidosis with neurological abnormalities such as confusion and ataxia. Acidosis, after lactic acidosis, it is the next most common cause of high 9-gap metabolic acidosis in ICU. Accumulation of ketone bodies is responsible for diabetic ketoacidosis and alcoholic ketoacidosis. Acetoacetate and beta-hydroxybutyrate are the main ketone bodies in the plasma which are neutralized by the bicarbonates. As the bicarbonates get used, so it will result in bicarbonates go down, these will go up, which results in high Ag acidosis. However, in alcoholic type, beta-hydroxybutyrate is the primary ketoacid acid but it cannot be detected by the routine nitroprusside test for ketonuria because nitroprusside can only estimate the acetone and acetoacetate. In starvation, there is excessive lipolysis leading to ketonurias. So in ICUs, you have patients of advanced renal failure. Advanced renal failure with GFR less than 20. Here, the decreased ammonia production required for buffering the H positive in the urine along with low excretion of sulfates, phosphates, and urates. They will result in high 9-gap metabolic acidosis. In liver failure, it is due to impaired lactate clearances. So these are very common causes after the lactic acidosis, ketoacidosis. These are examples of renal failures, hepatic failures. These all patients will have high 9-gap metabolic acidosis. Then in Indian setups, we also get so many patients. Recently in Punjab, we have toxic alcohol cases, methanol and ethylene glycol. Methanol leads to formation of organic acid, formic acid, leading to acidosis, blindness, and pancreatitis. Immediately administration of sodium bicarbonate reverses the acidosis, thereby lessening the tissue penetration of toxins. Fomepizole, 4-methylpyrazole, is a competitive inhibitor and serves to block the formation of formate. In severe cases, hemodialysis indicated to expel the toxic metabolites. So basically, soda bicarb and hemodialysis. Fomepizole I haven't seen as yet. It's there in the books, but we haven't seen it much. Ethyl alcohol after ingestion is metabolized to glycolic and oxalic acid. Treatment is almost on the same lines. So hemodialysis and initial management, supportive management is the key to the treatment. So we have isoniazides, salicylates. Isoniazides also causes the higher 9-gap metabolic acidosis. Symptoms include seizures. Salicylates I will go through in detail. The hallmark is combined respiratory alkalosis with high 9-gap metabolic acidosis. Salicylate overdose directly stimulates the respiratory center. At the same time, it's also responsible for increased production of lactic acid. However, the PCO2 might eventually start rising, and this is a very foreboding sign of poor prognosis. Management includes general supportive care, pure resuscitation, ventilatory support. Active charcoal may help if given within the first 2 to 3 hours. However, the most important aspect of management is alkalinization of urine with administration of soda bicarb, which enhances the elimination of salicylates. Hemodialysis is indicated in severe cases and is the most effective way of removing salicylates from the body. Word about non and N-gap acidosis. Loss of bicarbonates can occur from GIT as in diarrheas or from kidneys as in renal tubular acidosis. In these cases, there is a reciprocal increase in chlorides in the blood resulting in hyperchloremic non-gap metabolic acidosis. These are rarely life-threatening and resolve in correction of underlying cause. In urethral diversions using ileal conduits, the chloride from urine enters the colon and is reabsorbed in exchange for bicarbonate by the colonic mucosa. Similarly, pancreatic fluid, which is rich in bicarbonate, is lost to the pancreatic fistula. Renal causes the loss of bicarbonate due to impaired absorption from proximal tubules occurs in early renal failure. Again, it is counterbalanced by gain in chlorides. So it's a normal anion gap acidosis. In renal tubular acidosis, the kidneys fail to adequately manage the body acids, and this can occur due to impaired H-positive secretion, as in type distal 1 acidosis, which is commonly caused by autoimmune disorders like lupus. In proximal type 2, there is excessive loss of bicarbonate. So both types will result in acidosis, but the mechanism is different. So type 2 is seen in conditions like multiple myeloma, myeloidosis, kidney transplant patients having hepatotoxicity. Most common type of renal tubular acidosis is type 4, which occurs in settings of hypoaldosteronism and characteristically presents with hypokalemia. Iatrogenic causes like rapid infusion or large amounts of saline during resuscitation can also cause normal anion gap. Acidosis can be prevented by using balanced salt solutions. Metabolic alkalosis, this is something which is missed a lot. Measurement of delta gap is needed to differentiate between primary metabolic alkalosis and metabolic compensation of respiratory acidosis. So delta gap increases tell you of primary metabolic alkalosis. So whenever metabolic alkalosis is there, it reduces ionized calcium and may present with tetany or Kawasaki sign. It is important to assess the volume status of the patient in order to identify the type of metabolic alkalosis. Chloride resistance alkalosis is complained by volume overload, whereas those with chloride responsive usually volume depleted. Metabolic alkalosis is associated with hypertension, as in hyperaldosteronism, that is a primary, hyperparathyroidism, or the Cushing syndrome, renovascular hypertension, or very commonly we are using steroids in the ICUs and in the hospitals. They also cause metabolic alkalosis. If chloride responsive alkalosis occurs in presence of volume overload conditions like CHF, normal saline is to be avoided. So you are a chloride responsive alkalosis but volume overload. So normally chloride responsive alkalosis is volume depleted, but chloride responsive alkalosis occurring in volume overloaded conditions like congestive heart failure, then you have to avoid normal saline. But in potassium loss has to be replaced. So how will you replace potassium loss without using of volume? You will be using spironolactone or potassium sparing diuretics. Also for primary hyperaldosteronism, we have to use potassium sparing diuretics. To diagnose the cause of metabolic alkalosis, firstly, so if there is a metabolic alkalosis coming in the ABGs, you have to first rule out the normal causes. What are the normal causes of metabolic alkalosis? Vomiting, you are having continuous rise to aspirations, you are using antacids, including excessive use of soda bike, long standing use of diuretics, accelerated hypertension, hypokalemia. If you don't correct hypokalemia over a long period of time, it will cause metabolic alkalosis, and the mechanism is a bit different. So long-standing use of diuretics, aspirations, diuretics, and this hypokalemia. So if it metabolic alkalosis is coming in repeated ABG, then only we try to investigate, because metabolic alkalosis won't be that life-threatening as in acidosis. So what is the initial investigation? You go for urinary chloride level to differentiate between chloride responsive and chloride resistant. So I have given the list earlier, which are the causes of chloride responsive and chloride resistant. Causes of maintenance of sustained metabolic alkalosis are volume loss, contraction alkalosis, hypokalemia, and mineralocorticoid excess. Contraction alkalosis term is misleading because here the underlying mechanism is chloride loss, and it it shouldn't be essentially rectified by volume replacement, but rather by chloride replacement, even when we don't correct the volume deficit. A word about BECF. So in ABG, you will get a lot of these terms. Base excess is the amount of acid or base in millimoles per liter that must be added to the blood sample to reach a pH of 7.40 in standardized conditions, that is PCO 240 and 37-degree temperature. Base excess of extracellular fluid is a quantity that reflects only the non-respiratory component metabolic of acid-base disturbances. It can either be expressed for whole blood. So in ABG, you will be having BEBB and you will be having uh, BECF. So BEB means whole blood. It doesn't reflect the interaction of blood with interstitial fluid. And when it is expressed as ECF, BECF, it is with interaction of BECF. So which is better of the two? Better is BECF, which is a standard base excess. It is same as BECF, standard base excess. It is a composite marker. Several components contribute: chloride, lactate, albumin, keto acids. Thus, different components could operate in opposite directions, potentially cancelling out each other and making interpretation of isolated standard base excess difficult. It is calculated value, so it is not a measured value. It is a calculated value which relies on other measured variables like pH, PCO2, HB, and it assumes a normal plasma protein, so it can be fallacious. In short, an abnormal SPE is a reliable marker of an active metabolite. So if it's abnormal, then it is an active marker of a deranged metabolic issue. but a normal SBE doesn't rule it out. So it has got a good predictive value. So thank you everyone.